Thank you. Sir, can we start? Or
yeah, Manish, please. I think we're getting late now.
No problem. So I will start, sir. So, Palak, if you can please okay. So good evening, all. Thank you so much for sparing your time on a busy weekday of Wednesday. I am Manish. I'm the DGM Sales and Marketing of Converge Biotech. So I will take you through our journey. So Converge Biotech is a part of US $300 million group with footprints in pharmaceuticals, food processing, and real estate. We started our operation in 2015 and gradually moved to pan-India operation with 150 employee strength. Our core strength is a leadership team having a deep understanding and expertise in chronic and acute therapy markets and relationship with the key opinion leaders. We have a strong presence in critical care and cardiometabolic disorders with a coverage of more than 10,000 doctors. We have been awarded as the fastest growing company in 2017, an Emerging Entrepreneur Award in 2019 by Government of Telangana, and awarded the Emerging Company of the Year in 2020-21 Pharmaceuticals by Economic Times. So our team members, our Managing Director, Mr. Arun Kumar Vijala, he's a seasoned professional with 19 years of experience in sales and marketing domains, expertise in launching new business verticals and scaling it up. And Mr. Partha Rao Chaudhary has joined us in 2017, possesses a versatile experience for more than 25 years and highly skilled with managing people and managing operations. So our vision at Converge Biotech is aspiring to lift the community in leading a healthy life by formulating, developing, commercializing, and delivering reasonable and reachable medicines that gratify urgent medical needs. And our mission is pioneering therapeutic segment for quality medicine and create a segment in therapy areas like critical care, cardiometabolic, nephrology, dermatology, as well as gastroenterology. So at Converge Oncology, we believe that precision medicine is increasingly becoming important for advanced cancer patients. Certain therapies provide better patient treatment outcomes and fewer side effects than broad-based chemotherapy with precision medicine. And we firmly believe at Converge Biotech that every tumor type is different. And Converge Oncology is driven by the passion of a long-term commitment to oncology by offering personalized and precision treatment solution for each of your oncology patients. To take it forward, we have exclusively collaborated in India with OncoDNA. OncoDNA is a cancer theranostic company which has a global presence of more than 50 countries worldwide. And with this, I welcome you again to Concentric. Concentric is a Converge Oncology platform for excellence for nurturing therapeutic reasoning and conceptualization. So this is our first endeavor. Because of the COVID pandemic, we are connecting with you virtually, the first national summit. Going ahead, once things normalizes, we will also touch base with you for a national summit physically. So with this, I hand over to Dr. Shyam Agarwal. Dr. Shyam Agarwal obviously needs no introduction, but I will take the privilege in introducing you. Yeah, so he's the chairman and director of oncology at Sir Gangaram Hospital, New Delhi. He completed his MBBS from Chandigarh and then MD Medicine PGI from Medical College, Rohtak. Dr. Agarwal is a very renowned oncologist and hematologist in Delhi, AIIMS Delhi. He also underwent a special training at All India Institute of Medical Science in New Delhi. Dr. Agarwal He's also a bone marrow transplant expert from University of California, Los Angeles, USA, and St. Vincent Hospital, Sydney. He has enlightened many patients about bone marrow transplant, colorectal cancer, commonly known as colon cancer or bowel cancer. He has been a source of inspiration and guiding light for many people in the society at large. Being a noted oncologist, he has been awarded and facilitated with many awards and recognitions. He has been actively involved in creating awareness about the disorder and its eradication. With this, I hand over the platform to Dr. Shyam Agarwal. Sir, over to you.
Thank you, Mr. Manish, for those kind words and giving me this opportunity to welcome a galaxy of oncologists and research workers who have today joined us to enlighten on the emerging issues pertaining to precision medicine. I also welcome all the research workers and people who have joined us on the YouTube and on the Facebook to learn from this august group of oncologists and molecular biologists. I understand there are two foreign faculty members, Dr. Jean Francois Lace and Dr. Cheng Boon from UK, who have joined us to discuss the nuances pertaining to precision medicine. And of course, I can see on the faculty from India, actually who is who in the field of medical oncology is joining us today to really thrash out issues pertaining to lung cancer, breast cancer, and what is relevant to our country. So I think the journey started about 5 to 10 years ago with the emergence of next generation sequencing. And in the last, I think, 5 years, we've gone really much beyond that because people are not only talking about next generation sequencing, but people are looking at many other things, including HRR genes, HRD status, immune signatures, and with the introduction of immune checkpoint inhibitors, TMB, MSI. So, the list is sort of growing every day. And that's really adding very interesting vistas to the armamentarium of all oncologists who were just, having a few chemotherapy drugs until 5-7 years ago, and are now flooded not only with these drugs, but tools which we really need to understand before we employ onto our patients. So this meeting from Converge is one step in that direction, and I congratulate Converge and thank them for involving all of us in this discussion. So I think I won't stay between the faculty and the real treat which we are going to witness today. So Dr. Mehboob Basade, who is a senior consultant and a dear friend at Jaslok Hospital, who is held in esteemed regard from the oncology community all over the country and abroad. I invite him to take the program forward by inviting the first speaker. So over to Dr. Mehboob Basade.
Thank you, Shyam, and thank you, Converge, for inviting all of us over here. And it's going to be really good discussion as far as molecular profiling of all the various diseases is going to concern. So the first speaker is the OncoDNA solution is being done by the OncoDNA Global Medical Team. So I think let's start with them first. And am I right that first team is that? Because that's what is in the program is written.
Yes.
Yes, please.
Good evening, everyone. Thank you that you joined. Thank you that you give me this chance to present the OncoDNA portfolio. I will share my screen and we'll start with the presentation. Please let me know if you see my screen well.
Yes, your screen is visible, Lulia.
Okay. Oncodna company, it's innovative European theranostic company that focuses on precision oncology solution. And what is important that we have really patient-centric. What this means that we putting the patient the first to respectfully and with attention achieve the best experience and result for each patient and for their family. For this point, each of oncologists can request from us pre-consultation according to some clinical case, and we will come back to you and advise if this patient is really good candidate for molecular profiling test. From other side, we have a scientific approach. So the main goal is supporting oncologists around the world to providing useful recommendation that based on strong and up-to-date clinical and biological evidence, combined with really in-depth knowledge and successful experience in molecular profiling. And for this side, we propose after each test, after each report, receive a post-reporting consultation with our scientific expert in molecular profiling to clarify all questions that possible. OncoDNA mission, it's really to improve all patient health through patient care. And we really like to bring personalized medicine to every patient. And our mission is empowering doctors, physicians, biopharma company, and researchers to deliver the promise of precision medicine to patients with cancer or genetic disease. OncoDNA started in 2012. It's a theranostic company. And today we're really transforming into a big data and artificial intelligence company. So during 9 years, we built a really unique system of data management and data interpretation solutions that today benefits all who involved in cancer care. The OncoDNA headquarters based in Belgium. And we have other participable parts, Integragen Group, in the company specialized on description of human genome, and Biosequence company located in Spain. So today we have a group of employers, approximately 115 employers in 9 different countries. And we have a network with 35 official distributors over the world. And we collaborate with Europe and US-based subcontracted accredited laboratories. And we successfully collaborate with biopharma and international biopharma company, and happy invite oncologists and patients for new projects. Today, we're really proud to have official partner in India, and we invite each of you to contact Converge Biotech with full confidence and trust. Now it's time to present to you our portfolio, and today we have 3 different solutions in our portfolio bag. So it's a Oncotype Test, is the solid biopsy test, and 2 liquid biopsy tests, OncoSelect and OncoFollow. Let's start from OncoDeep, and it's most of comprehensive solution available on the market. We recommend this test for stage 3 and 4 solid tumors in adults. And today, OncoDeep really offers unique combination of molecular diagnostic and genomic profiling tests that targeted a large panel of genes, so more 600 genes, and tumor-specific biomarkers, so additional tests. So we provide information from different levels, DNA, RNA, and proteins. to really propose recommendation according different type of therapy, targeted therapy, immunotherapy, hormone therapy, chemotherapy, and clinical trials information. In case that were not possible to obtain a solid biopsy sample, it's so old or condition of patient not good and not possible to take a new biopsy, we have a solution from liquid. We need only 2 tubes of blood, and we can recommend it for stage 4 solid tumors, 3 cancer types. It's non-small lung cancer, breast cancer, and colorectal cancer. So we propose really selected and smart panel of genes from 7 to 12 according to cancer type, and recommendation according sensitive or resistant to approved targeted therapy. We also have a specific first personalized liquid biopsy test in the market, Oncofollow. Oncofollow test based on analysis of circulating tumor DNA in blood, and it's used to monitor the progression of the tumor and detect the lack of response of resistance to treatment as soon as it appears. So it's really can be customized, a personalized approach that where we analyze up to 15 variants from previous identified from previous sequencing. And in addition, we do a fixed panel about 40 genes that associate with sensitive or resistant to targeted and immunotherapy. So Oncodna becomes the really first company to launch personalized liquid biopsy test. We also effective and very carefully for reporting system. So we create a special platform, OncoShare, for oncologists around the world to quick get a report of patient results. And here available 2 versions. One is dynamic report through platform, and you always can load in a PDF format, paper version. Our platform OncoShare shows the result of your patient molecular profiling through really online integrated theranostic report that include different sections such as comprehensive biological and clinical information, biomarker status, drugs, clinical trials, and bibliography part. That's important. So you will have really access to all publication, article, abstracts that associated with this clinical case and report results. Let's summarize and see the complete Oncodna decision process. So at the beginning, we need to receive a biological sample, depending what analysis you choose. It can be solid sample for OncoDeep or liquid for OncoSelect Oncofollow. We receive the samples in Belgium and provide full analysis in our partner lab, Institute Pathology Genetics. The next step is interpretation, and we use our appropriate database, OncoKDO, that today include all last and updated clinical and biological data according to variants, proteins, drugs, clinical trials. And this database really updated every day by our scientific team, so you can be sure that in result will be include only last and new relevant data. The next step is publishing. So after report is published on OncoShare, oncologists receive email with information that report is ready. Final decision always through oncologist. So you take a final decision and share your recommendation during the consultation with your patient. We have all needed accreditations for Europe, and we respect really personal data. So each of tests have a specific barcode. To summary, we really working for you, for each of you, to support you in molecular profiling decision and support your patient with personalized approach. OncoDNA provide a customer support service. We open to pre and post-reporting scientific consultation. We're happy to organize different webinars and roundtables and support you in some scientific academic research projects and publications. It's my last slide, and thank you for attention. And I wish you a good webinar and good presentations.
Thank you, Dr. Leila, and for that information regarding what tests are available through the platform. So let's move to the next one by Dr. Cheng Boon from UK. He will be discussing about improving patient care outcomes through the deep insights. Dr. Cheng.
Thank you. Manesh,
yeah. Sorry, it should be presentation by Dr. Jean-François Laes.
Okay, yep.
If it's correct,
yep. Should we? Is it Jeff's turn?
Are you ready to share screen, or I can support you? Let me know.
It's okay. I can start sharing screen. No problem. Can you see my screen?
Yes.
Okay, perfect. So thank you, everybody. So I will show you how precision medicine can bring a very deep insight for your patient. So clearly, as already mentioned by Julia, the idea is to improve patient outcomes through a comprehensive analysis. And the idea is really to target the right patient for the right cancer at the right moment. And this is what, but the idea behind is really to make precision medicine a reality in order to really target, as I mentioned, the right patient, the right cancer, and improve patient outcomes. And what we know is that not all the cancers are equivalent. You are facing very often highly aggressive, rare cancer, where actually patients do not answer to standard of care. And you need really to identify those patients as fast as possible, at diagnostic, and adapt directly the treatment to improve and cure those cancer types. Also, as you know, with the latest approval, there are more and more treatments that are pan-cancer. And those treatments are actually associated with very rare mutation. And we know that if a patient has this mutation, he or she will answer the treatment. So it's really important to detect those very rare mutations as earlier as possible, because we know that the benefit for the patient will be really high. And last but not least, complexity is increasing. We clearly see that at the moment there are more and more combination of treatment, immunotherapy, targeted therapy, chemotherapy. And if we want to address this complexity, we really need to have a very accurate tool to predict which treatment or combination treatment might be associated with the best benefit for the patient. And the question then is, which cancer type are we talking about? So in OncoDNA, we are addressing solid tumor only, meaning that we are not taking care in hematological cancer like leukemia, lymphoma, or myeloblastima, not because those cancers are not important, just because we don't have the expertise. So our expertise is focused on solid tumor, stage 3, or stage 4 in adult, with the exception of glioblastoma for pediatric patients. And we do also have a special solution for CUPS, or cancer of unknown primary, in order to identify the probable origin of the cancer, as well as the treatment that might be associated with a clinical benefit for the patient. And we do believe, and especially now with the COVID situation, which increased the situation, so we have more and more cancer with highly aggressive states, is that those tests should be performed at diagnosis because time matters. And if we have the entire information at the early beginning, clearly it will be associated with a benefit for the patient. But also we need to address those when the first line is not working. Because, you know, for some first line, you have a biomarker and then the patient is not answering anymore. And the question is, which treatment to give as a second line based on which biomarker? Because you know that the usual suspect, you know, that guide you for the first line are not present anymore. There is a resistance that you have to decipher. And as mentioned by Julia, how to do that? So we spent more than a year to build first a database called Oncotype, because you have to know your enemy, meaning that we really look at the literature to know what are the variants, what are the biological impact, the therapeutical impact, the clinical trial that are ongoing, the treatment, approval, etc., etc. And this is a daily job, which means that we have a team of scientists who are fetching the information on internet on all those parameters. And we are reading the article. We are not just looking at the title or the abstract. We go deeper into the article to make sure that the information is correct. And then we are updating our database. Based on this, we were able to build different solutions, Oncotype for solid biopsy and OncoFollow and OncoSelect for liquid biopsy, but I will move more into detail afterwards. And then we show the report based on a web-based platform that you can share with colleagues and the patients. So if I go back to Oncotype, actually Oncotype, first of all, is based on next generation sequencing of the DNA. So the sequencing on the DNA, and we have a very comprehensive panel which can address tumor mutational burden, MSI, HRD. There is 638 genes, but there is no 638 actionable gene in cancer. Actually, we are using those genes in order to have more power or enough power to really be able to calculate the tumor mutational burden in a very efficient way. We are also looking at, translocation through DNA. So in routine, by default, we are using an RNA-seq panel. But, when you're talking with, for instance, about non-small cell lung cancer, we know that the biopsy is very often not contributive because the RNA is degraded or there is not enough quantity of RNA. Therefore, we are using this DNA as a backup when the RNA is not working. And what makes us different from most of the, if not all the solution, is actually we are combining the sequencing of the DNA with some additional tests. Because we know that not everything is written in the DNA. You have the expression of hormonal receptor, you have methylation of the MGMT, you can have the mTOR pathway that has to be activated to make sure that anti-mTOR will work. And we are complementing the next generation sequencing by those additional tests. And actually, this is really useful. So a few years ago, we made a publication with more than 1,000 patients where we combine the percentage of biomarker identified by the sequencing of the DNA and the actionability of the combination of the sequencing and those additional tests. And we found that only in 27% of the patient, we were able to identify something that was useful for the patient. And this is not related with our test. This is just related with biology. And when you add these additional tests, which are cancer tailor-based, meaning that we are not doing the same test for all the cancer type, we are building those tests based on clinical evidence. we were able to identify something useful for the patient in 92.6 or point something percent of the patient. So clearly, the combination of the sequencing of the DNA and the analysis of some additional, so some protein or other biomarkers improve the chance for the patient to have something useful for their treatment. So if I summarize, here based on the DNA, we are able to identify biomarkers associated with targeted therapy, immunotherapy, like PARP inhibitor also, for instance, which is something that is increasing in some difficult cancer like ovarian, pancreas, and prostate. If we combine this sequencing of the DNA with this additional test, actually we can address other biomarkers, other therapies like chemotherapies, hormonotherapies, but still targeted and immunotherapies. And thanks to our CUP solution, within one analysis, we are able to identify the probable origin of the cancer. And in parallel, we identify biomarkers that might be useful for the patient, meaning that you have the combination of two information in one report. And also the comprehensiveness of the report is key. Because here you have the ideal situation where you have a bundle of people spending hours looking at literature, browsing internet, trying to find a treatment for the patient. But actually the reality is completely different. I mean, very often you have about 15 to 20 minutes with a patient to make a decision, which means that the information you will receive has to be very comprehensive to really help you in your decision. So our goal is not to replace the oncologist, not at all. This is not our job. Our job is to provide you with something comprehensive and useful for the patient, like a sophisticated PET scan, if I can make this analogy. And this is why we decided since the beginning to provide you with the report in a web-based platform, which means that you can have access to the report anywhere in the world, even if you are traveling at home. And you can share this report with colleagues if you need a second advice or if you want to discuss about a special case. But of course, we know that for regulatory purposes, you need PDF report, at least in some countries. I don't know what is the situation in India, but in a lot of countries, you need a PDF report, which is also something that you can share with the patient. And last but not least, you are not working alone, which means that we are not providing you with a cat in a box. So we have dedicated teams that you can contact where you are thinking to send us a sample for analysis, because you would like to know, is the biopsy young enough? Does it make sense regarding the cancer type, et cetera, et cetera. Of course, we have the power to tell you that, in our opinion, this is not the best case. But at the end of the day, this is your decision, but at least you know what you are doing. You have the control of everything. And also, when we are after the publication of a report, you can also contact us to discuss the conclusion, the result of the report, to make sure that you fully understood everything and you are ready to make your decision. Also, very often, the solid biopsy is too hard. So I mean, it doesn't make sense to make an analysis on a biopsy that has 1 year or 2 years old, because the tumor has evolved, you treat the patient, everything is different. So the conclusion will not be accurate. Then what to do for the patient? This is why we developed this liquid biopsy test, where for some cancer type, we can look at some key biomarker in the blood by using the ctDNA to guide you to some targeted therapies. Also, when you are treating a patient, the question is how to monitor the evolution of the patient and how to identify as soon as possible a relapse. because we know that the sooner you are identifying a relapse, the better the patient will answer the next treatment. This is why we develop this personalized monitoring by looking at variant within the ctDNA. And why to personalize this? You know, with ctDNA, it's a fantastic tool when it's positive. When it's negative, the question is it negative because of the biology? Because we know that not all the tumor are shedding ctDNA in the blood? Or is it negative because the tumor shrunk and almost disappeared? If you are analyzing a fixed panel, actually the probability to have a false negative is high. If you are analyzing, a bundle of biomarkers that you know that are present in the tumor, which means that all those biomarkers will be, or almost all of them, will be present in all the clones of the tumor. When you have a negative result, it's very unlikely that this is a false negative result. It's the probability that it's really associated with a shrinkage of the tumor is really high. So to make a conclusion, precision medicine require comprehensive test that should be performed at diagnosis, has to be robust because FFPE samples is a complex matrix. Has to be associated with clinical evidence to make sure that we provide you with the best results and conclusions. You also need a support for interpretation. And last but not least, we need also to have solution, non-invasive solution, where you don't have access to the solid biopsy, or if the solid biopsy is too old. Thank you very much.
Thank you. And I hand over to Dr. Shyam Agarwal, please.
Thank you, Dr. Mehboob, and thank you for that comprehensive lecture, giving us insight into the detailed analysis. So I think let's just come to the practical discussion, which is going to be focused on non-small cell lung cancer. So Dr. D.C. Doval, who is the Director of Medical Oncology at Rajiv Gandhi, is the chairperson for that moderation and discussion. Dr. Doval, please kindly take it over.
Hello, good evening to all of you. And I think the first case study is on role of molecular profiling in precision medicine, non-small cell lung cancer. And this panel will be moderated by Dr. Nitesh Srodki, who is eminent oncologist from Max Saket. Dr. Nitesh Srodki, please.
Thank you very much. First of all, thank you to organizers for having me here. Can I invite my panelists first, Dr. Chen Boon, Dr. Krupashankar? I could not see him. I don't know if he's there. Dr. Shankar, yeah, he's there. Fantastic. Yeah, I'm here. Yeah, Dr. Sheikh from Mumbai, Dr. Piyush Bajpayee, Dr. Mosmi Sulivanchi, Dr. Salesh Bundade from Nasik, Dr. Bhavesh, Dr. Pawan Raghav Reddy, and Dr. Rajkumar. Do I have all my panelists? I think without going into detail of this, very interesting two talks we've heard. I do think that there's a lot of molecular oncology happening across the world. India is no exception. In fact, we've had some really interesting discussions on that in the last few months. I'll go through this case, but I will actually stop in between, even as we discuss the case, to see what are the practical aspects of managing non-small cell lung cancer in the first place. So this is a 48-year-old current smoking male with non-small cell lung cancer. And he develops metastatic non-small cell lung cancer with bone, lung, liver mets. And we do a biopsy which shows TTF1 is positive, P63 and P40 is negative, and there's a glandular differentiation with more than 15 millimeter. Can I maybe start with Dr. Krupa Shankar himself and say, so what's your belief that considering this patient, and I put it in bold, is a current smoker, male, should we be taking this as adenocarcinoma truly, or do you think that these are often adenosquames, and how do you decipher that? Because these are small biopsies.
So again, sir, I think you've done the IHC markers as well, for which TTF1 is positive. You could also probably do a napsin A as well. This is also more specific for adenocarcinoma. And given that the P40 and P63 are negative, that pretty much rules out a squamous cell carcinoma. So I'm pretty happy with taking this as a non-small cell lung cancer adenocarcinoma. And given that he's a current smoker as well.
So you're saying even if the biopsy specimens are small, and even if this is a block made out of TBNA and stuff like that, but if the IHC is very confirmatory for positivity of adeno and negativity of squame, maybe we should just proceed like that. Okay. Dr. Cheng Booth, you there?
Yes, yes.
Does this raise doubts in your mind when you're practicing in UK that if this is a current smoker, even if there's a clear-cut adenocarcinoma, maybe there's a squamous component to it?
So in the Western world, the EGFR mutation is much rarer. And if you look at the original trials, most of the patients were from the Far East and non-smokers. So you do want to make sure that you're testing the correct test and it's valid. So you made a very important point. You have to look at your population. I would suggest being very careful if it's a smoker and the EGFR, particularly the
I
Western
think you're actually bringing me to my next question, which was that this routine test for EGFR, ROS, and ALK was performed. I have not mentioned how they were performed. I have not mentioned whether positive or negative, but I've not even mentioned how they performed. So could you tell us what's your view on how should an EGFR, ALK, and ROS perform, and what's the benefit versus harm of different technologies that can be applied?
So in the NHS, if you're having treatment in the NHS, which means the civil service is paying for it, they want you to do one at a time. They want you to do all the immunohistochemistry because it's cheap, like what you do TTF1, P63, all that. And then you do PCR and FISH one by one. You do the EGFR, you look for the T790 mutation, and then you do the ROS one, ALK1. There are differences in Europe and UK. In Europe, there are small panels. You can do EGFR, ROS, ALK as a sort of a mini NGS. So there is no standardization in Europe. In the NHS, it's easy because it's paid for by one, the government is paying for it. So they can set the rules, you follow their rules, and then you treat them. If your patient is being treated in the private sector, then it's different. Then the clinician get to decide, insurers, you justify it, you can get all the tests done. You can do NGS right at the beginning. You can do Oncotype and the OncoSelect at the same time because you do the liquid biopsy and the solid biopsy, and then you track the mutation, as what Dr. Jeff was saying earlier. That's one of the difficulties we have. We don't have one way of dealing with the heterogeneous data that we're getting. And as oncologists, we still have to realize the tissue we have. Are you getting a big sample, a small sample? If you're doing like the NHS, sample by sample, you quickly run out of tissue as well. So that's the other issue you have to be aware of.
Okay, I know I can see Mosmi there as well. Mosmi, do you feel that doing a solid and a liquid biopsy is actually adding to, maybe I'm not talking about finding more information, but final impact on quantity and quality of patient lives? I mean, the two options, and considering the cost in India, is to do it in the sequence, which is you do in the solid tissue, you don't find much, or the tissue is inadequate, you do liquid, versus saying let's do a solid liquid combined panel, and really how does it help in terms of patient care improving when you talk about 100 patients together? Mosmi?
Okay, yes. So if money is not a concern, I think liquid biopsy along with solid is helpful. So in our institute, for most, at least for EGFR, liquid biopsy is done before the tissue biopsy is coming. So, and that helps the clinician to initiate the treatment first. That is one aspect. And the various data which have come have clearly shown that if you combine both of them, the number of targets are definitely more. And tissue biopsy, many times you're not able to get enough tissue for NGS or even for single gene testing. So that is the thing. If you can combine more information, faster TAT turnaround time. So those are the advantages.
And do you also feel NGS is the gold standard now, or would you say that actually RT-PCR and the FISH for Ross and the ALK would be considered still gold standard as compared to NGS?
I feel NGS is the gold standard. So, because in our country, cost is a concern. We are still going for single gene testing at many places. But once you do NGS, there is so much more to it. You may miss so many exon, like 20 insertions, EGFR insertions in your routine single gene testing, and maybe so many mechanisms of resistance which are happening in single gene testing. So I don't think there is a comparison.
Okay, so I'm going to call Dr. Muzammil Sheikh to tell me what he would do in reaction to this 858R being positive. But so far, what we've heard is that from both Dr. Boone and from Dr. Suryavanshi, that it seems logical to do actually a paired testing. TAT is low, although NHS is not doing it exactly like that, but there should be potential benefit both in terms of being gold standard as well as TAT, as well as picking up rare mutations, which we do know impact patients' quality and quantity of life, because the wrong treatment is never useful. Dr. Sheikh, what's your view on how would you react to this patient 858R being positive?
There is a target which you have identified in this patient, although the clinical scenario was of a smoker, but adenocarcinoma, current smokers also, the percentage is less, but we do find EGFR activating mutations. So for me, if a mutation is positive, there are drugs to treat this, based on the affordability and patient's discussion. We choose possibly the third generation or at least the second generation of EGFR inhibitors.
Piyush, Dr. Piyush Bajpai, what would be your choice of drug, cost not being a constraint?
Yes, so again, if cost not a constraint, then of course, third generation TKI is what I would choose.
So there's been some debates happening in the last few months about looking at flora slightly differently and looking at the Asian population specifically, looking at the 858 specifically, and saying that actually the advantage may be so driven by deletion 19 that 858 curves are coinciding. And in fact, second generation TKI, both afatinib and dacomitinib, may be having an advantage there. Do you see that data as being a game changing in practice?
So broadly speaking, Dr. Nitesh, L858R is slightly more aggressive disease variant as exon 19, and the failures in brain are a bit concerning. So if a third generation can delay that failures or control those failures, so that would be important.
There was a delay in the Archers, which had no brain mets in that inclusion criteria, but there was a decreased amount of progression in the brain in the group that was on dacomitinib. I don't think that's proof because that was retrospective and that was subgroup, but even then, Dr. Boone, are you segregating osimertinib versus dacomitinib? What would be your practice in the private practice in UK and NHS with the 858R?
In the NHS, there is nice guidance. So the NHS has negotiated a special discount from crizotinib manufacturers. So they are allowed to use third generation crizotinib upfront.
Osimertinib, I think you meant.
The manufacturer offers, osimertinib, osimertinib third generation with a discount. And that's because the NHS is a single payer. They can negotiate that kind of pricing. But if the clinician, based on their experience or based on their choice or based on the patient's fitness, choose to use first generation, I don't think it's wrong because that's also allowed. And if they have the subsequent escape T790, you can still use the OSI after that. And now it becomes very complicated because do you test them second line or do you test them after progression? This is where you have to think about, are you going to do a biopsy, a liquid biopsy to track it? So it opens more because the cost is not just the drug, but the cost of tracking these mutations, how you going to change.
Okay, thank you. So this patient was started on osimertinib as Piyush and Dr. Sheikh was suggesting, but I don't think entirely unexpectedly, there was liquid biopsy done, and no EGFR resistant variant was detected in the blood, but the patient did show an asymptomatic cancer progression on the scan. So this was a very interesting situation where actually your blood is negative. CFDNA, CTCs have not gone up or not been detected, but there is a small amount of lymph node and some bone progression, not in crisis. And I would not say there was a rampant increase, but by research criteria, there was a progression. Dr. Salesh, what would you do in this situation where you've seen a radiological progression on something which we are used to follow up? That's a guideline, and we've got a liquid biopsy which is not detecting something. How would you react to this oligo progression, if I may call it? Although I've said multiple small, so that's not oligo, but low volume progression.
So, I mean, it can differ from person to person, like whether to treat the oligo progression as a local progression with some local therapy and continue with the systemic therapy without changing it, or to change it if the progression is really significant. It depends on person to person and patient to patient.
So I guess in this patient, there is asymptomatic, small volume, but multiple areas. So you can't really radiate those areas and continue with the TKI. So would you change, or would you say that this is low volume progression? I would wait for a bit longer to change?
Actually, I would feel that progressing in 3 months is not a good sign. So had it been say 18 months, 19 months, maybe you can continue the same TKI and go for a local treatment. But I think there needs to be some action at this stage if the patient is progressing within 3 months. That's for sure.
So you're absolutely right. The action was taken. The osimertinib was continued, but the action taken was that Oncotype was ordered. And the Oncotype was ordered on the previous lung biopsy. I put that in bold because what we'll see is that there was a change in the previous biopsy where this was not a resistance mechanism to the EGFR TKI, but a patient who had an unusual splicing met exon 14, in fact, at diagnosis, and was not picked up because there was initial testing, as Mosmi very rightly put, not using NGS. And the minute we use NGS, in fact, we saw there was already a met exon 14 and the TMB was very high. Can I pass the podium to Dr. Bhavesh and say, now that you know that we have a patient who has been put on osimertinib, is 858, Piyush very rightly said, this is a word prognostic group. At 3 months, you're seeing a radiological progression. Patient is completely asymptomatic as well. And another 2 weeks later, you get a report saying this patient has a high TMB and a met exon 14. So first to Bhavesh, met exon 14, and then maybe to Dr. Raghav Reddy to say, how do you read TMB in this group of patients?
So definitely first, when we have a target, we have to work on that. So met exon 14 will be targeted first, and God forbids if it doesn't work, then probably we'll do something which is TMB high related.
So are you planning to stop osimertinib, or you going to add something to osimertinib?
So even on, as we can see that Oncotype has not identified EGFR, and it is also gone from the blood. So probably I think targeting that with osimertinib, which is not there at all, may not be a good, it not be advantageous. So we can just switch to anti-met rather than continuing or combining both, which will be again more toxic than single agent.
Okay, and what about Dr. Raghav Reddy? How do you read the high TMB? Are you going to use this information in managing this patient?
Not right now, sir. So if we go by the history, a patient has progressed within 3 months of starting osimertinib. So probably it is not an EGFR mutation that is driving the cancer, but probably that MET exon 14 mutation is probably driving this cancer. So I would be more tempted to give, offer targeted therapy targeting the MET exon 14. I would like to reserve immunotherapy for the TMB high for the subsequent line.
I'll come back to you, Mosmi. I think you want to make a point.
Yeah, I feel that the first diagnosis, the molecular diagnosis of L858R might have been wrong. It is very unlikely the same biopsy, a driver mutation like L858R missed on NGS. So probably this patient didn't have L858R. This is what I feel, and patient has not responded also to osimertinib. So
I think
patient,
NGS was not performed to begin with, right?
yes, so probably that L858 whatever single gene was.
What is the false positivity rate of a standard RT-PCR testing that we're doing these days?
Actually, if like the tissue is correct, you've taken it from the right person, it is hard there, it is cannot be false positive. So probably there's some mix up, because I feel at times your RT-PCR, if it is just looking at one mutation, is more accurate, more diagnostic than your NGS, because NGS might because there are a lot of procedures they're happening there, it might miss.
I hear what you're saying, but unfortunately patients develop disease without reading the book. So I think all these true genuine problems also happen. We have seen all kind of, I think, multiclonal disease in patients. Why, if you pick up a part of tissue, these are all rare. I'm not saying this happens, but
I want to add a point that this NGS was done from the same biopsy.
Same biopsy, same
How
biopsy.
it could have been missed? So that is my point.
I don't know, mostly. All I'm saying is I've seen everything in the last 10 years go topsy-turvy and wrong. So these things happen. Dr. Shyam Agrawal, sir, you want to make a point too?
No, I put it in the chat box. What is the role of VAF in somatic mutations?
Can I get maybe Mosmi to answer that? She's already there.
Yeah, okay. Variant allele frequency, usually for most of the solid tumor panel, what most of the people are reporting are anything above 5% is the variant allele frequency. For liquid biopsy, it is different game, because there you may have lot of mutations coming from clonal hematopoiesis. So if you have very low variant allele frequencies, or like 0.1 to 0.3, or in genes like TP53, KRAS, so they may not be actually driver mutations or something. Usually the VAF for driver mutation is high, at least higher than 5, 10, maybe 50 also at times. So it is there. So usually the driver mutations have a high VAF.
I think that's a very important point Mosmi makes, and we must read the information taking that into account. I was very impressed by the initial presentation from the OncoDNA group, where there is a provision to discuss this report with the molecular biologist and the clinician. And I think my learning has been that no matter how much I read, how many cases I've gone through, there's always that something new that shows up. Dr. Rajkumar, can I pass on to you? This patient was started on a MET inhibitor and then monitored with blood biopsy. Is that something that you think you would do? Your previous colleagues said they would like to do that. Dr. Rajkumar? Okay, so he's not there. Dr. Boone, is this drug available for you in UK? Capmatinib?
In the NHS, I would not be using this. This is not available on the NICE guidance, but what would happen is the clinician can write to the drug company and ask for compassionate access. And they do give it.
Any experience of capmatinib?
No, I treat actually upper GI cancers in my NHS practice, but I don't treat MET inhibitors because I don't even check for it.
Dr. Shyam Agrawal, have you had experience with the drug, sir?
No, I think we are referring for trial at the moment, so on the ongoing trials, yeah.
Okay, so very interesting. The treatment worked, but further progression after 8 months. This was picked up a liquid biopsy which had no EGFR variant detected and no MET exon 14. So we again have a situation where I think we've all already accepted that this patient was possibly never EGFR mutated. However, we on liquid biopsy still could not find a MET exon 14. I don't know if Dr. Moon wants to opine whether there are mutations which actually do not shed in the liquid biopsy, or is that not the case?
Well, one of the difficulties is that you're doing liquid biopsy, but you have to see how fit the patient, whether you could repeat tissue biopsy. The second thing is this patient is a smoker, there's high TMB, so you're constantly having new mutations, and we don't know whether they're significant or not, or whether it's smoking related. You're not given chemotherapy, so it's hard to say one or the other. You have a limited test. You have to see whether your patient is fit enough.
Yeah. Okay. So I think that's exactly what happened. I'll pass on.
Can I add a point? Can I add a point?
Please, mostly.
So in liquid biopsy, when you look at a report which has nothing, like no driver mutation, so it should be taken in two contests. One is uninformative or negative. So if there is some mutation, maybe like a KRAS or something, so the mutation it is not being shed, but it is not uninformative, it is negative. So if you have, on the other hand, there is nothing like here, so this is uninformative, you don't know, so it has been shed or it is not been shed, so that
Okay,
part has to be fixed.
So let me say this again. You're saying that on liquid biopsy, you may have a change in cell-free DNA and a CTC, but you may not have the cell-free DNA of the mutation for which you're treating, and that's actually an uninformative versus saying there is zero cfDNA and gone from 5% to 0, and that is either a response or other way around. I think that's a great point you make. Dr. Shyam Agrawal, sir?
I mean, if the tumor is regressing, so would the the mutation, the thing will not regress and disappear, because if there is a CR or a good PR, so would it not be representing that in the ctDNA report?
Usually we see that. And in my own experience, I've got a couple of patients on Guardant and even on Indian equivalent. And we've seen that some patients actually are never shedders, and some are shedders that respond. And it is very reassuring to see a high cfDNA, high CTCs go from a 20 to a 1, or cfDNA go from 11% to 3. But there are patients who actually never shed, and you can have a situation where, and I've seen that in pancreatic cancer in 2 patients, where they just did not shed mutations, so therefore it was not a much use in either increase or decrease. Dr. Boone, I think you wanted to make a comment on that.
So this is the point was made very well by Dr. Mushumi. Liquid biopsy is not 100%, and you have to make that judgment whether you want to go for solid tissue if you can't find anything. But once you reach the point where it's progressing clinically, you might not be well enough, and the point is you're giving a targeted treatment. You're not giving a cytotoxic agent, so you're just targeting one pathway. So if you have a high TMB tumor, whether that's the right thing, you're just attacking one pathway.
Okay, I'm going to go to Dr. Krupa Shankar next. Would this have been a choice of therapy, pembrolizumab, single agent for TMB high patient who's PDL1 low, or I didn't actually say what the PDL1 was, but hypothetically, let's presume it's 5%. Would you give single agent pembrolizumab second line in a patient who has been chemo naive? So this is second line for target, chemo naive, pembrolizumab, TMB high, PDL1 moderate, smoker.
Yeah. So probably my choice of therapy in this patient, probably when he's progressed on initially an EGFR TKI and then a MET inhibitor as well, where he's progressed on capmatinib as well. So 2 lines. On the 3rd line, I would have chosen the ABCP regimen, if at all I want to choose the atezolizumab, Bev, and paclitaxel. And the reason I say that is because it's only based on a subgroup analysis where they looked at EGFR mutant patients as well. And there was a magnitude of benefit in those patients as well. So thereby my reasoning for choosing the ABCP regimen. And also just a brief mention about resistance. I mean, like we were discussing about EGFR resistance. I think we need to understand that there are primary mechanisms of resistance and secondary resistance as well. So, I mean, like we've had patients as well. I mean, I've had a patient recently who progressed within a couple of months. And unfortunately, later on, when I looked it up, the patient had a KRAS mutation as well. And that's a reason for a primary resistance, where the patient can actually progress in a couple of months' time. So I thought that's something which is worth sharing. And also the point about doing an NGS on liquid biopsy upfront. I think the point is we're able to pick up uncommon mutations as well. Like, for example, if you're doing a hotspot mutation analysis on RT-PCR, even if it's only on EGFR, we're only looking at exons 18 to 21. Whereas you could have around 10% of uncommon mutations as well. And that is just to drive home a point, sir.
Okay, I think I buy your point. I must move forward. Piyush, there has been a lot of debate on two different aspects of this. Patients with mutation should not be maybe given single agent immunotherapy. Yet he's a smoker, and we know that there's data on smokers and second line, at least atezolizumab and maybe nivolumab. More than 1% PD-L1 second line nivolumab is good candidate. This patient is chemo naive. I will want your opinion on what would you suggest for this patient.
No, I agree with Dr. Krupa on this, that the data for atezo chemotherapy and bevacizumab is there. So, which has looked into the small subset of prior treated EGFR TKI patients. Here again, the patient is progressing rapidly over a period of 3 months. Though we did a NGS over here, but sometimes if one is not suspecting or one is straight away looking, that could also be another option with a high TMB. So we got this TMB report on the Oncodeep analysis.
Correct,
was it?
Correct. And I think the problem with TMB has been it's all over the place. We don't know its value in immunotherapy single agent. We have some data of nivolumab and TMB in immunochemotherapy with nivolumab, and we have certainly some more data when you use IO-IO combination. So, but we don't really still know where to put it. I think it's just something which came out, and there's been a lot of debate that it's a surrogate for smoking. So if somebody is a smoker, you could give that anyway, irrespective of TMB. Your views, Piyush?
So I would have, Dr. Nitesh, I mean, either given two options to the patient if my patient progresses on 3 months on osimertinib, and that would be one, go for a biopsy or go for a such type of testing, again Oncodeep or more comprehensive test if it's not done earlier. Number two is also considering looking towards an immunotherapy approach.
Okay,
so for immunotherapy, atezo I would choose.
Yes. I'm hearing that there is some benefit of adding chemotherapy because we are unsure, but I'm also hearing that immunotherapy for sure now because he's high TMB, he's smoker, and we have already said at least once we got this wrong. Sorry, I think I went a bit ahead. This patient did well on pembrolizumab single agent with no signs of relapse at 6 months, which he is still on. I'll go one by one. I'll start with Dr. Shailesh. How do you choose the right candidate for NGS, Dr. Shailesh? And I think that's my last slide. After that, I'll end.
So for me, preferably, because tissue is always an issue. Going for a sequential, you may land up with having less tissue for further NGS if required. So if possible, always upfront, if the patient can go for an NGS, that's my first choice.
And smokers, non-smokers?
Either way.
Either ways, okay. I have some views on that, but I'll carry on. Dr. Bhavesh, how do you choose the right lab for NGS?
It will depend upon accessibility for patient as well as the turnaround time. So both will be important because we have to get onto the treatment faster. So it will be cost of course is always there. So turnaround time, availability, and cost.
So I think my algorithm starts with the cost and then comes down to everything else. I would certainly want Mosmi's view on this. Mosmi, in 3 lines, what are the 3 things medical oncologists must look at? M in capital, U in capital, S in capital, T in capital, before they send a tissue to NGS to any lab. I think cost is priority anyway.
Yes. So to any lab, the tissue has to be adequate, number one. And because there are so
I'm
many.
talking about the lab. How do we choose the right lab?
Okay, in NGS, actually there is a lot of validation and accreditation required. So I think you should go for an accredited lab. It should not be, that part should not be compromised. And the validation, your and lab should have the right panels. So if you're doing a lung thing, you don't need a 500 or a 600 gene panel. So you should choose the right panel if they have offer, so that you can optimize on money also. And then it should be able to give you the DNA, RNA, and copy number, all those things. And if you're looking for beyond that, TMB, MSI, or whatever, so that should also be available in your panel. So whatever your requirement is, that should be there.
Thank you. Dr. Booth, you want to make a point there?
Yes, thank you. I agree. We have to choose the accredited lab, but the cost of NGS is actually coming down. So my point was, there are actually companies that will do the whole genetic sequence, 22,000 genes, that is beyond what any oncologist, any human would be able to analyze. And there are those who will do like 3 or 4 genes, and that will be also a small panel. In future, I think the cost of actually doing 400, 500, 600, 700 compared to a small panel actually will come down, and it will come down because of the volume you do. If you have a very big lab and you do a big panel, it doesn't matter because the cost of it is already built in. The panel is fixed price. What they do is they'll cover all pan tumor. That's why they cover that. So it may actually be artificial cost saving. By doing a small panel, you actually have to have more panels. It's more confusing.
So in summary, we should send everything to OncoDNA or to Boston, one of them, so that we can bring the cost down.
No, but actually, that's the reality. We know that all companies will try and increase their panel because it's easier. You don't want to make the mistake. This was a stomach cancer. You did the lung cancer panel, then you're in trouble.
Jokes aside, I am running short of time. Dr. Bhavesh, very quickly, you've been stuck with a report which is difficult to interpret. You're finding yourself in a corner. What do you do?
So if finance is permit, I would repeat it. But
no,
if
no,
not, then
interpretation only.
So no, I didn't get the question.
So there's a report from the best lab in the world. Oncodeep's giving you the report, but you don't really know how to use that clinically. I'm saying, how do you?
Oh, okay. So you have markers, but you don't have treatment for that. That's what you want to say?
Partly, and partly you don't know how to optimize the information. You've got 3 mutations running. You don't know if the sequence will work. There's so much information which is not mathematical. It's not mutation, drug, give the drug. How do you use that information, which is quite complex, on the page 1 of each of these reports?
So I think the more commoner the mutation, I would treat that first, and then go for the rarer mutations. So I think that would be the sequence.
Dr. Reddy, if you've got a patient where there is a EGFR on an NGS report, along with a MET, this patient already on TKI, and he's suddenly shown a P53 as well, what would you do in that patient? Who will you call? And don't call me, and don't call Bosme, and don't call Dr. Boone. I'll ask Dr. Boone in a minute. Who will you call?
I'll probably call the expert from the Oncotype, team and ask them for guidance, as they had rightly mentioned in the beginning.
Okay, so I'll answer that very quickly. Each of a good labs actually have either a panel or a molecular board, and I think I'm insisting that these are complicated reports unless they're very straightforward, single mutation EGFR deletion 19, or a KRAS which tells you that actually there is a lack of treatment option. You must take it to a molecular board. Dr. Boone, please make a point. I'll move on.
The point is, in Europe, in UK, everybody is asking the same question: who is going to interpret it for you? Who is going to offer you the treatment? If you offer the treatment, if something goes wrong, will you be sued? It's very difficult. So in Europe, there's something called something like a genomic MDT, where you get other oncologists to double check that your treatment is okay, your lab results are valid, is reproducible. Those are the things they will check, because you're making a big change here. You're skipping completely chemotherapy. You're giving a treatment that may or may not be, like MET inhibitors may or may not be licensed, and you're giving it based on the fact that you're based on one report. So you want somebody to support you if things don't go out 100%, because we cannot be certain. We're oncologists. It's
in India, we have Dr. Mosmi Suryavanshi doing that job for us. So thank you. Okay, Dr. Rajkumar, you've got a drug. It's not available in India. It's FDA approved. It's a Pfizer, Roche, Eli Lilly, or Novartis drug. What are the methodologies of getting that drug? Okay, I can't see him. Maybe Dr. Sheikh, could you take that? There's a drug which is available abroad. The companies are available in India. How would you get that drug? Let's say MET inhibitor at the moment, in fact. That's a good example. Okay, I can't see him either. Dr. Piyush Bajpai?
Yeah, I think so. Like you mentioned, Pfizer Cares is there, and then on you can approach Novartis, I guess, for capmatinib.
Yeah, I think
so. There are, if you go looking for the compassionate basis programs, yes, one way. Yeah.
Yeah, so I think we underuse the compassionate use program. I know Dr. Shyam Agrawal has been very big advocate of it, and I have recently realized how useful it is both to gain experience and to actually get the drug much lower in the cost than when it really arrives in the country, which is always going to be higher. I do need to end. Does the report help in planning immunotherapy? It certainly does. This was a great example showing the same. This is the Oncodeep, which we have already discussed about. The question is primary or metastatic tissue, but not older than 6 months. My personal view is metastatic. And I think that whole idea of a liquid biopsy along with that is quite fantastic if it in the same cost. So my only advice to the company is please bring the cost down. Actually bring the cost down. Thank you very much for my panel. I really enjoyed that.
Thank you.
Thank you.
Dr. Doval may have left. Dr. Shyam Agrawal, can you take over, please, sir?
Yeah, okay. If Dr. Doval is not there, so thanks, Dr. Nitesh and your panelists for this insightful discussion. So we move on. I see Dr. Harit Chaturvedi, who's a senior surgical oncologist and chairman Max Institute of Cancer in Delhi. So Dr. Harit, over to you. Yeah, please.
Thank you, Dr. Shyam, for having me here. I think I went through this panel. It was really very insightful. Even surgeons need to know the changing world. It's very rapidly evolving. And I think between this panel on lung cancer and the breast cancer, we have a very, very important talk by Dr. Senthil Rajappa, who will give us the Indian perspective on the molecular profiling and what we are doing with it. And Senthil needs no introduction. He's a very eminent senior medical oncologist from Indo-American Institute, Hyderabad. And I have heard him n number of times. I'm sure most of us have heard him several times. And we are up for a very good treat on this important topic. Welcome, Senthil, for this.
Good evening, everybody. Thank you, sir, for that very kind introduction. And thank you, organizers, for asking me to speak on this topic, which is Indian perspective, molecular profiling, and precision medicine in patient outcomes. So the essence of the talk will be what's happening in the community and what should we be doing to implement precision oncology better. Now, this is the Globocon statistic on the top left of your slide. You see that in 2020, just over 13 lakh cases of cancer were diagnosed. And look at the dismal figure as far as deaths are concerned. A significant proportion of them, which is more than 50%, die because of their cancer. Of course, the reasons for this dismal figure is multifactorial. But if we need to get better, get to the next step as far as improving the survival is concerned, I think we need to adopt precision medicine. And what I'm showing in the bottom right of your slide is the number of studies going on just in non-small cell lung cancer. And look at the date, that's 2018. So more than 2,000 plus trials just with immuno-oncology plus a targeted agent. So that's the kind of research that's going on in this field. And if you're not going to get to there, you're not going to get better. And the question is not whether you get there or not. The question is how to get there. And let's see if we can try to answer those questions. Now, in the community, you look at doing broad profiling or trying to implement precision medicine in 3 specific situations. One is adopting a standard of care treatment. The second is in a situation where no standard treatment is available or nothing is remaining. You still have a patient with good performance status and you want to profile and enroll on a clinical trial or use an off-label indication therapy. And then the third one is everyone else. Who's that everyone else? This is a group of patients whom we profile in order to look for experimental therapies or enrollment on a clinical trial. So these are 3 broad patient populations. And we'll try to look at what's the data available. There's very little data from India that is available, but I'll take some population-based data that has been published from the Western world, which also includes some Asian populations to drive home certain points that I wish to make today. Nitesh did a lovely panel. This is nothing new to all of us. From 2013 to 2018, there's an explosion of targeted therapies for non-small cell lung cancer. And all these societies, and ISALC is not an exception, what they say is do multiplex genetic sequencing panels. We're not talking about a 350 gene panel. At least do a broad panel for targets for which you have at least an approved therapy. And this is expanding by the day. And as you get more drugs, the panel will keep getting wider and we need to be ready for that. But the question is not that. The question is, look at this paper that was published in the JTO in 2020. That's not far long back. Now, beyond, this is in the community, this is looking at all geographies, Asia down to Latin America and some unclassifiable group called rest of the world. Now, beyond EGFR and ALK, testing for other biomarkers has been disappointing. Only 1 in 10 will get tested for ROS, a target that's been with us for nearly a decade, should I say. And there's hardly any data for BRAF, right? So this is the status in the community, and this is an IASLC sponsored study. So this is by an independent organization. So it's quite authentic. And this is what is happening in the society. Patients don't get the testing that they deserve. And there are various reasons, and some of them are listed on the top right corner of this slide. But this is the reality. Let's go a step forward. What is the applicability or what's happening in the real world cohort in terms of multi-gene NGS? Again, this is lung cancer. Lung cancer is the poster boy for precision medicine. And this is what is happening to the poster boy. 14% had actionable alterations over on top of EGFR and ALK. And look at the percentage who get NGS guided therapies over on top of EGFR and ALK, 4.5%. And the Kaplan-Meier projection on the right for nearly 1,000 patients tells you that because of lack of access to therapy, the outcomes are no different for patients who had broad panel testing, which is what is recommended and is appropriate, versus patients who were treated routinely with or without a broad panel testing, with or without a treatment. So the point is that we may sit here in glass cases and talk about broad panel NGS, TMB and stuff like that. But remember that in the real world, the testing rates and outcomes are far from ideal, and that's very, very important. So how do you try to go through this data? Now, let's look at the Esmo recommendation. The Esmo recommendation says that you have a broad panel testing for the conditions that are listed on the table. Small cell lung, non-small cell lung cancer is one, cholangio is another, ovarian, prostate. These are situations where it is cost effective to do a broad panel testing. Why? Because you need to test for a lot of genes. They've got targeted therapies. Testing for each one will exhaust your tissue. It's also more expensive. So that is why the ESMO says that in these conditions, you do broad panel testing. But remember that when you're sitting with a patient, it's easy to say that the ESMO is asking you to do this. But if your patient cannot access that therapy, now this access can be from the market, can be from a compassionate basis, can be from a clinical trial, or if your patient cannot afford that therapy, then what's the point in really testing? If you're doing some research, it's okay. And if you're sponsoring the test, it's okay. But if you want your patient to do the test, then you should be ready with the therapy that is necessary to answer the targets that will show up based on that test. Now, in research setting and in clinical trials, all solid tumors should be tested. When it comes to an individual, especially the second category that we discussed earlier, that is, they don't have any standard therapies, I think that should be very, very individualized. Now, this is how India has used immune checkpoint inhibitors in lung cancer. Now, this is from some investigators and also from the companies where they've helped me with this data. Now, in 2019 and 2020, 18 months, partly COVID times, this is how we've used immune checkpoint inhibitors. The reason why I'm telling you this is that access to therapies is possible, but the affordability is poor, patient selection is poor, that a significant proportion of patients who actually start on an expensive therapy don't even get to beyond 4 doses of that therapy. Look at this. By dose 12, which is even less than a year, 91% of patients have actually dropped out. So remember that if you're suggesting something that your patient cannot afford or take continuously, this is what is going to happen. And whatever little your patient took is also going to be a waste. So please discuss this with your patient before going ahead with testing. Let's look at category number 2, where no standard treatment is available or remaining. Now, this is a snapshot of the various molecular precision medicine test drive trials, right? You start with MSK Impact and you go down to Moscato. Look at the numbers that you started with, 10,000 here, 1,000 here. Molecular profiling was possible for majority of patients. The average is around 86. Actionable alterations were found in about 40%. But look at matched trials. You get only about 10% of patients who get into these matched trials. For the NCI match, that's gone up from 11% to nearly 17%. So when you start with a huge population, remember that not everybody will get entry into a clinical trial, again, for various reasons that we don't have time to discuss today. So this is a number that you should clearly remember. Now, that is on a clinical trial. Now, this is a very recent publication from the Journal of Precision Oncology, which looked at a very important center in Europe and looked at how they are able to apply precision oncology in breast cancer, a very common tumor. They enrolled 200 patients, of which only about 130 could be discussed in a molecular tumor board. Now, based on the discussion in the molecular tumor board, they could treat about 64 patients. And look at what you end up on that 64. You've got a 6% partial response and a 10% stable disease. Now, remember, this is an important center in Europe. Patients go through a molecular tumor board, and this is where you end up with. And the reason is very obvious. You might have a lot of recommendations from a molecular tumor board, but look at the blue versus the red. The blue is recommended, the red is implemented. Wherever you have therapies that are easy to adopt, PIK3CA inhibitor, endocrine therapy, TKIs, all these are areas where it's easy to implement. But these are areas where the molecular tumor board said, use this, use that, ADCs, FGFR specific inhibitors, and look at the implementation rate. It's hardly anything. And did that end up improving the overall survival? It didn't. And the reason is not because the therapies are wrong. It's because many of these are not implementable in real world practice. This is from another center in Munich. Again, a recent publication, 2021. Lots of patients enrolled. This is just breast and gynec. Started with 95 patients and very little end up having clinical benefit. So when you're doing this in a situation where standard therapies are not available, even when you go through a molecular tumor board, there are a lot of stumbling blocks and you don't get to the outcome that is desired. Now, this is data from our own country. Now, this is a study that was proposed by Dr. Aju Matthew from Ernakulam, and about 12 of us got together to pool in our data to see what this looks like. So this is titled The Benefit of CGP for Advanced Cancers in India. So this was done over 2019 and 20. This excluded patients who had an identified target for which an FDA-approved drug is available for that anatomical site. For example, EGFR in lung would be excluded from this study. We looked at only solid tumors. So we got data from 297 patients, of which 223 met the inclusion criteria. And the most common tumors are listed here. 90 plus had a tissue biopsy and a small percentage had a liquid biopsy. Now, these are the results. I won't go into the details of it for want of time. So you started with 297 patients. And based on this data, 4% had clinical benefits. And this is from our country. The list of mutations for which the various drugs that were used are on the right side of this. The reasons for not getting targeted therapy are patients were still on standard of care, or the second most common reason was their performance status was poor. So the applicability of this in the real world seems to be not so great. So why is this dichotomy? We talk so much about precision medicine, but when it comes to the real world, the results are not that very promising. I think the reason is this, right? What is actionable for you and me need not necessarily be actionable for the patient. For the patient, this is the question. Can we identify a drug that will reduce my suffering and make me live longer? I think that's the question that most of us will not be able to answer because our definition of what is actionable is quite different. So having said that, we need to adopt precision medicine. We need to get into it. How do you really close this gap? Efficacy in clinical trials versus effectiveness in real world practice versus cost effectiveness. These are the things I think we should be doing. We should do broad panel testing. There's no doubt about it. The panel made that very, very clear. Nitesh did a lovely job. Test standardization and interpretation is extremely important. You might use a rating or a ranking like the SCAT from Esmo so that in the real world, it is easy to apply these. Access to targeted therapies are very important if this is going to be successful. As was very clearly pointed out by Dr. Boone, cautious therapies off-label, right? We might say use an immune checkpoint inhibitor plus a PIK3CA inhibitor plus a PARP inhibitor. That's very easy to recommend. But in reality, that's not easy to use. Toxicity, financial toxicity, and doubts regarding efficacy will always keep us, guarded when somebody says this is what you want to do. Testing at the right time, and most importantly, realistic expectations. Both the doctor and the patient should have realistic expectations out of the test that is being ordered. I think this is the bottleneck. Nitesh again asked the question, how do you choose the lab? I think majority of labs who do a good job, accredited and all of these, I think the consensus target should not be necessarily about the technology. We've got great technology. But I think the more important thing is also a relevant question that was discussed. It's about bioinformatics, interpretation, and the recommendations as far as the treatment is concerned. So what should we do in India to implement precision medicine? I think the first thing is educate everybody and encourage testing. Remember, precision medicine is here to stay. We cannot run away with it. We have to get to it. So only if you do, you will see that you're seeing these targets. And only if you see, you will believe. And so the first step is to getting to test. We all have to emphasize on testing where approved therapies with proven clinical benefit exist, because if you do that and you see that it's benefiting, then you can move to those gray areas where you could start using molecular tumor boards and doing off-label therapies. A lot was spoken about cost, the panel, and the turnaround time. We need to develop central testing so that there will be more samples that will shorten the turnaround time and decrease the cost. Very, very important. Molecular tumor boards, try to be a part of one, because that's an area where you share, learn, and you probably will implement some of those words of wisdom that you get from seniors and colleagues in a molecular tumor board. You will learn so much from being a part of a tumor board like that. So get to somebody who will help you to do that. And I think ultimately access to drugs and clinical trials are very important. It might be a biosimilar, it might be a genetic, it might be in a clinical trial, it might be compassionate basis. Get to that drug, learn how to get access to these difficult to access drugs, and that will make this easy. I think for anything to succeed, attitude, access, and affordability is important. And if something does not touch the Indian middle class, it's not going to be a success. So anything that we do should be implementable and accessible for the Indian middle class. And the best treatment is what the patient can actually take. So my final slide, we've got a long way to go, but I'm sure we will reach that sometime. Precision medicine is real. Though we are far from claiming success, we are still in our infancy, or I would say India is a neonate there. Advancements in technology and bioinformatics will improve targeting. So we need to keep trying to improve our interpretation and apply this knowledge. And as newer accessible therapies will enhance our ability to treat, that's when you go back and test more. Remember, I think this is a very important point, that precision medicine is not a panacea. It's not going to solve all your problems. And remember that it is a tool. For me, in this area, the sky is the limit, but very important is that you don't get lost in the clouds as you're trying to reach the sky. You need to get some clarity as you go by, and this is the science that you learn on the go. Thanks so much, all of you, for that patient hearing. If there is any time for questions, I'm happy to answer. Otherwise, Dr. Raja is there to conduct your panel, which will be much more interesting. Thank you so much, and back to you, sir.
Thank you, Senthil, for this wonderful talk. I can only say that what I have heard so far, it's a team sport. While it's about precision medicine, I think only by pooling and learning and engaging, we will learn from this. So thank you very much, and back to Dr. Shyam.
Thanks, Harit, and thanks, Dr. Senthil, for that wonderful talk, showing us the reality as it stands today. And so I have the pleasure and the privilege of introducing Dr. S.S. Nirni, who's a senior medical oncologist at the Omega Hospitals in Hyderabad. So Dr. Nirni, please take over. Please unmute yourself. Please unmute yourself.
Yeah. Now I will invite Dr. T. Raja, the senior medical oncologist at Chennai, to discuss about second case about rule of molecular profiling and precision medicine in breast cancer. Dr. T. Raja.
Thank you, Dr. Nirni, for the kind invitation. Thank you so much. Allow me to share my screen. I think my screen is visible and I'm audible. And I'm very thankful to Dr. Shyam Agarwal, sir, for inviting me to be here. And then, it's a pleasure. And also, I thank the Converge and Concentric for putting us all together for this, very insightful discussion. It's an emerging field, as we heard from the previous speakers, and as our senior Dr. Harit said, it's a team sport. I think he clearly summarized it very well. So I will go into a panel discussion on breast cancer, the role of precision medicine and molecular profiling. I have a case that was given to me by the Converge Concentric, and I have a couple of my own cases. Probably I'll be able to present one or two of that. Let's see how to negotiate this conundrum of dealing with precision medicine. And the first patient is a lady who has got a HER2 positive and hormone receptor negative breast cancer. That's what we have. And she's a 51-year-old woman with breast cancer, and the pathology shows that she has an early breast cancer and lobular disease, and is HER2 positive and ER and PR negative. And she goes through the standard procedures like surgery, adjuvant, therapy with EAC followed by trastuzumab and taxane, and was fine for 1 year. So this is something that you would routinely see in several of your patients. As it happens very often, this patient then went on to have a relapse after 1 year, and now she has got a metastatic disease. And then the pathological review, once again, from the primary site was carefully looked at, and still HER2 positive, 3+ FISH was also done. It was also positive, and the primary site is ER and PR negative. And therefore, she was treated with pertuzumab and trastuzumab plus paclitaxel based on the Cleopatra data. And she achieves a very good complete response on the primary site, but she has progression on the liver metastasis. So at this point, we are stuck. We need to move forward. So that's where I want to know what our panelists would do. At this juncture, I also want to invite Professor Jean Francois and Dr. Cheng Boon also to join the panel to enlighten us on some of the molecular aspects. But I'll first begin with my Indian colleagues. Dr. Meenu Walia is here. Dr. Meenu, a lady has progressed, too fast, too soon, and then pertuzumab, trastuzumab, and here is the twist. She has a very good response in the primary site, but has got a progression in the liver metastasis, kind of a differential response. Dr. Meenu, how shall we approach this lady? Dr. Meenu, you have to unmute yourself.
Yeah, Dr. Raja. Hello.
Yes, now you're audible.
Yeah. So just wanted to clarify, this is the case you said that she was operated and post-op we had given post-op we had given trastuzumab based therapy, and
That's
now the relapse was only in the liver.
Liver secondaries.
The liver secondaries, there is no primary.
Relapse in the primary site also. Both.
There was a local relapse also, and there was a relapse
also on the liver.
And there was a relapse in the metastatic in the liver mets also.
Liver mets, and when you treated them with a double antibody, the key point is there is a differential response. There is a very good response in one site, and there is a progression in another site. That's the key point.
So my take on it is when it was a recurrence, did we do a liver biopsy also, or it was a biopsy only from the local recurrence?
As I told you, until now, it is not done. So that's why we are consulting you. What should we do at this point?
So I would like to do a biopsy from the liver side and look at, confirm that it is the tumor only, and again look at the nature. Whether it is ER, PR, and HER2/neu, what is the status of the disease in the liver? And another point which I've also wanted to, in case suppose it comes out to be the same. So is it multiple liver mets or it is a solitary liver mets?
So at this point, it was multiple liver mets, and you are perfectly right. We want to know what's going on in the liver, and therefore we have done the liver biopsy. We have taken your advice. We have done the liver biopsy. That's what we have done. So I will, ask my another colleague, Dr. Chetan. We see a differential response, and as Dr. Meenu pointed out, we are keen to look at what's there in the liver. We have biopsied, and as I have posted here, this biopsy was sent for an NGS analysis. But Dr. Chetan, what are your indications to consider a broad panel NGS testing in a breast cancer? When would you consider it, Dr. Chetan? Dr. Chetan Deshmukh.
Yeah, thank you, sir. Usually we offer a broad panel testing at first relapse, because in the first presentation, we are good to go with the standard IHC or biomarkers which are available in the form of ER, PR, and HER2. It's only at the relapse setting, and especially when the relapse has come up just at 1 year or so, that we are looking at options. So this would be a typical scenario when one would like to do an NGS.
Fine. So unlike the lung cancer, even in a metastatic breast cancer, on progression, so that's what you pointed out. But there are some, interesting thoughts about knowing something earlier with regard to say PIK3CA and also, that's fine. But in general, most of us do it on relapse or on progression. And then the biopsy was done, and it was also analyzed, and then an NGS was also done. But when the liver biopsy was analyzed, it was found that the ERPR were still negative, and the HER2 also was negative, FISH was negative, and the ERBB2 genomic application actually in the NGS was also negative. So it turns out to be a slightly different situation at this point. So this is what has happened. Dr. Ghanshyam, how often do we see that receptor-driven disease, HER2 positive disease, on evolution, we turn out to have a triple negative breast cancer? So do we face this, and what do we do with these situations?
Yeah, so according to literature, so I think there are around 14 to 15%. So you may see a patient losing on HER2 amplification. So, and that was probably the reason that the patient had a differential response. So we know that there is always some amount of discordance between the primary and a metastatic site. So now since it has become a triple negative at this moment, so now it becomes more important to do a broad-based genomic analysis, because you know that there are many other things like the BRCA will come into picture, the HRR will come into picture, and like PIK3. So that will help us in actually deciding a more rational treatment as compared to patients who are HER2 positive. So triple negative is probably the more genomic. So besides the PDL1, the MSI, so all those we need to do in this patient now.
Yeah, I think you are very right. You touched upon two things. Doing a broad panel would enhance your knowledge. And then you also pointed out something important, that among the breast cancers, the triple negative has got more genomic instability, and you will find a lot of genomic instability in the broad panel NGS in triple negative. And then comes the HER2 positive disease, and then the hormone receptor positive disease. Not necessarily in that order, but triple negative definitely. So I'll ask Dr. Cheng Boon, Dr. Cheng, in the UK, for a breast cancer, if you have to order a broad panel NGS, when would you order that? What does NICE allow you to do, Dr. Cheng?
So in the UK, if you're on the government service, NICE guidance would say not for any broad panel, because the government of the UK did a NICE analysis in, is it 2016? A bit like what Dr. Senthil's data had shown. In 2016, there were no systemic treatment for targeted treatment yet. So the data at that point says no. So NICE had actually turned NGS down, and that was CARES. In this situation, most of these patients would come to us, either they go privately or pay privately, because there's a lot of breast cancer patients in the younger population who are still working, who can afford this, because they're in the Western world. The cost of this to them is actually affordable. The question becomes, if you find a mutation, can you get the drug companies to give you the treatment? So then it becomes more difficult. Do you crowdfund? Do you get insurers to pay, or do they sell their assets to try and fund the treatment? So sometimes we do see that. My only point I want to make is from the liver biopsy, occasionally we'll find that it's a small needle biopsy, and this has happened even in my own patient, but the sample is little. OncoDeep version 7 would do NGS plus a bit of immunohistochemistry front for you if you have the tissue. But if you don't have enough tissue, which would you choose? Would you choose NGS, or would you choose the immunohistochemistry with the EL1?
Yeah, that's a clinical question. I mean, if I obviously, depending on the tissue, everything has to be decided. And for example, in this patient, we did stumble upon that. We detected that it just changes character, triple negative. It can happen, as Dr. Ghanshyam pointed out, in certain percentage. And then if I have some more tissue, then that's the workflow pattern. Then we would ask that to be sent for a complete NGS. So that's the way it happens in the clinic. But tissue will always be an issue. But fortunately, in this patient, as it happened, there were tissue, and that was sent for both routine IHC, so on and so forth. I will talk to Dr. Seema. Dr. Seema Gulia is there. She is in a very prestigious institute. Dr. Seema, in breast cancer, as everyone pointed out, and as Dr. Cheng pointed out, the NICE still doesn't allow a broad panel testing early on. But in the metastatic breast cancer, does it make sense now to know more, to look into the NGS early on? For example, my argument will be that in hormone receptor positive disease, I may know the PIK3CA and its prognostic. And in a HER2-driven disease, I may be worried about profiling them for a HER2 enrichment, so on and so forth. Does it make sense, Dr. Seema? What is your advice? When should we do a broad panel in metastatic breast cancer?
So my first disclaimer is that we do not routinely do NGS panel in breast cancer in our center.
Perfect.
And
what would you aspire to do?
Yeah, so as you have rightly pointed out, the patient who are hormone receptor positive and metastatic, doing their NGS panel to look at PI3K mutation might be helpful because we have a targeted therapy available, but not so for HER2 positive. And in this patient population, in this patient particularly, where there is a differential response and where clinically we are suspecting that there might be a change in receptor status, or we have run out of the available therapies, in those selected patients we might think of doing, but not as a routine practice.
Fine. So you would still reserve, even though you see that there is a lot of scope in doing and learning, but still out of practical reasons. I totally see your point. I will talk to Dr. Bhushan from Nasik. This is the Oncotype report. I've just given the front end of this, and this is how the Oncotype NGS report starts. And this patient went on to have this kind of an NGS report. BRCA1 and 2 wild type, PALB2 R414 detected, and then an HRD scoring was done, and homologous recombinant deficiency HRD score was positive. This is what we have in front of you. Like the previous panel and also with the previous speakers, how would you negotiate with this NGS report? What would you do, Dr. Bhushan?
Yeah, obviously I would first disclaimer, I would not do NGS. Like I would do the targeted mutation, like particularly BRCA in this case. And now this patient has come BRCA wild type. But even if I do a wild NGS test, then this report doesn't carry any meaning to me.
Dr. Bhushan, I think we have briefly lost you.
Hello.
Yes, Dr. Bhushan, please go ahead.
Yeah, sorry. So I usually don't do NGS. Hello.
Yeah, Dr. Bhushan, I think I've heard the gist of it. You don't do NGS routinely, and that's what I heard. But for some reason, it has been done, and there is a report, and maybe your colleague has done, or I have done, and they've reached out to you. So what will you do, Dr. Bhushan?
Now, this is not a targetable mutation, at least in India. So I would definitely treat like a TNBC, routine TNBC patient. I would add PDL1 also in this patient, and treat like a routine TNBC patient rather than going and doing a targeted therapy as per the NGS.
Okay. Yeah, so we'll come to that. We will debate the nitty-gritty of this particular test. Then I'll go to Dr. Shivakumar. Dr. Shivakumar from Salem. Dr. Shivakumar, one good question Dr. Cheng was asking, and Ghanshyam pointed out, we have lost the HER2 here, and we have something funny here. Whether we are going to react to the PALB2 or not, we'll come to that. But should we continue or discontinue the HER2-directed therapy? That's what he wanted to ask. Can you take that question, Dr. Shivakumar? What is your thought?
So essentially, the tumor become now a triple negative. So that's what the issue says.
You want to react to the older, phenotype, or would you want to still do something to that older HER2 expression, or you just want to move on and address the HER2 positivity? Sorry, triple negativity.
So I will address this tumor as a triple negative, sir. I won't go back to the older thoughts.
I don't think anybody can. Shyam Agarwal is laughing, but I think that's
my only question, Dr. Raja, is that patient's primary is responding to the triple drug therapy.
So you want to continue that?
I don't know. I mean, this is what we are discussing here.
So we'll come to that. Okay. So this PALB2 was done, And I will talk to Dr. Jean Francois. Dr. Jean Francois, the PALB2 is done. So I am able to look at some of the data set. I'm going to look at the cosmic. I'm able to, and it is identified that this R414 is pathogenic. And then I looked at the ClinVar, and I have access to, in our institute, we have a direct link with the University of Utah, and we run all our findings. And if I have a VUS, I run it across, and I can get back from them that this is a pathogenic variant, and sometimes it's already available in the public domain. But my question to you is, Dr. Jane Francois, whenever we see variation, and then I get everything, I get a VUS there and so on and so forth. Sometimes I get a copy number, so on and so forth. But then how do you clearly say that it is pathogenic? Almost always. How do you decide that particular part of your advice, Dr. Jean Francois? Professor Jean Francois, are you there?
Yes, sorry. Could you repeat the question, because the sound was...
I said that I have a PALB2, and then I could run that on a cosmic database or a ClinVar database. In my institute, we have access to the University of Utah, which is the largest database for the VUS, and I'm sure you're aware of that. And we may take the help of various other NGS team like you. And here it's clearly defined as a pathogenic variant. But then if I am in doubt, how would you, as a molecular biologist from the center, would advise that this is a pathogenic variant or not? If suppose you have to advise on it, what do you do to do that?
At the moment, we are reading the article, which means that however, we have access also to ClinVar, OncoKB, Cosmic, and the other database. Actually, what we are doing in routine is that we are reading the article and we are looking whether, as those articles associated in vitro, in vivo, in human, associated with clinical trial, and then based on this, we are labeling the variant as pathogenic, but with clinical evidence.
Fine. So you talked about that in your talk. You talked about using the bioinformatics and really going deep, and then enhance it. That's how you advise. I heard about that, but I can definitely also quote some examples. We have had a splice variant, BRCA splice variant, where all of us were breaking our head whether this is really pathogenic or not. So there can be some difficult issues. Now coming to the PALB2 function itself, and Dr. Ghanshyam, I think I can really ask you. I know that you would be able to take this. How does PALB2 really kind of confer to produce a breast cancer? What does it do, Dr. Ghanshyam?
Yeah, so we have been discussing about this in the HRR panels also, about in the other cancers also. So I think so these patients has so HRR deficient. So these patients, for me, in a clinical sense, they can be a candidate for a PARP inhibitor. So in the broadest sense, as the clinical implication goes, so they can be a candidate for me as a PARP inhibitors.
Okay. No problem. I mean, since I had the opportunity to read up, I must say that I totally take up. But when I read, I was very fascinated. The PALB2 is actually a present and localizer of a BRCA2. Actually, it recruits the BRCA2 and the RAD51 into the scenario. That's what. So that's why actually it turns out to be more powerful than a BRCA2. It's not as powerful as BRCA1, but it's more powerful than BRCA2, because this is the one that actually fetches the BRCA2 into the scenario to do a double standard DNA repair. And it also recruits the RAD51 into the scenario to do that. So therefore, when PALB2 is mutated, the whole repair mechanism goes on, and therefore it becomes significant. And now, as we are sure, all of us know, there are excellent data sets both for olaparib and also for talazoparib that as an expanded access, some of the patients with PALB2 is included in these data sets, and they have already demonstrated. So we'll move on. So this patient, who based on that was put on compassionate use of talazoparib, fine. And the patient did respond very well. So that's fine. So that's taken for granted. But I'm coming to a different point. I will go back to Professor Jean Francois. I went into the entire NGS report of this, and I was so fascinated. Apart from the usual biomarkers that are given, the Converge and Concentric is trying to give all these biomarkers. It talks about, it talks about TMB, it talks about HRD, it talks about, androgen receptors, PDL1. I don't know whether they are talking about PDL1 by IHC or PDL1 amplification. So this is very fascinating, and they have given a conclusion on HRD, and they have qualified this patient's HRD score to be 35, which is very, very high, as we know. And then they have also done a beautiful analysis on TMB, and they've given immunogram. So I was so fascinated when I went through the entire report, and this patient TMB value turns out to be 9.86, which we know is quite higher. As far as breast cancer goes, the usual average TMB is around 3 to 4, most of them, at least the hormone receptor positive, except in triple negative, it can be at this high level. So this is your comprehensive report, immunogram, so on and so forth. So I'm very impressed. Can you talk about what do you do in the lab and in the back when you put all these things together and advise us, Dr. Jean Francois?
Yeah, sure. As mentioned, so we are doing all the tests, separately. So we are looking at the expression of PDL1, CD8, performing next generation sequencing. And actually, we developed algorithms that are gathering all the data together. And then it talks to our database, and then based on this database, either all the biomarkers are moving in the same way, then it's pretty straightforward. But sometimes, actually, you have one biomarker who's saying yes, and another one who's saying no. And then we need to make a human interpretation. But most of the things are automatized thanks to our IT system and our database. And I would say that in more or less 90% of the case, everything is moving in the right direction, but sometimes things are more complicated and you need a human interpretation.
That's perfectly right, sir. I have the other patient where that illustrates that just having a sophisticated NGS report is going to be more difficult to deal with the patient. This patient, in essence, for want of time, I will quickly go into the crux of the matter. This is a hormone receptor positive disease treated with metastatic disease, treated with chemotherapy, and that was way back in 2017, and then was put on aromatase inhibitors, progressed, and then was put on CDK4/6 inhibitor, and then progressed and was started on some form of chemotherapy, and an NGS was sent. This is a liquid biopsy, and this is what I get. So I will come back to a complicated report at this point. We will go into the nitty-gritty of this, but I will turn to my clinicians. Dr. Meenu, when I am presented with this kind of a report where I see that this is a liquid biopsy, but the tumor fraction is very high, 35%. But it shows that the TMB is 23 mutations, and there is a BRCA2 with a VAF of 72%, and there is an ESR1 and MDM2, and then there are other ancillary findings. So, Dr. Meenu, I have a more complicated NGS report. How do you react to that? How do you take it forward?
I can't see it on my screen.
Okay, I say that this is a liquid biopsy which shows multiple variations like a BRCA2, ESR1, and has got a TMB high. So that's the question. So you can just take that question, and then if there is a very complicated NGS which doesn't have a single actionable, but it has got a multiple actionable items, what do we do, Dr. Meena, in that? Or I can ask Dr. Seema. Dr. Seema, if you're able to see this NGS report.
Yeah, I can see that NGS report. And the most striking feature here is that BRCA2 VA frequency is 72%, which is not absolute, but it gives a hint that probably this is germline mutation. This gave me some indication depending upon the variant allele frequency, which is more than 50%. So in this case, probably I would act on BRCA2 and consider her for a PARP inhibitor therapy. I could see that she's also ESR1 mutated. but she has already received fulvestrant and she has progressed on fulvestrant. And she's 71-year-old. I'm not sure how she will be able to tolerate alpelisib or any PIK3CA inhibitor. So for her, based on this NGS report, my choice of therapy would be any PARP inhibitor, talazoparib or olaparib.
Perfect. It's a very good analysis. Then I will turn to Professor Jean Francois. Professor, we have this kind of a complicated NGS. And how do you go through this and advise if we come to you, if we call up and say that we want to have a one-on-one with your team, and how do we negotiate this particular report?
You schedule. This is complicated because you have a TMB BRCA2, and you can schedule a call and then we can discuss this. But here, the patient is quite old, sounds HR positive, HER2 negative because she received fulvestrant. So for me, this is strange because you could put on PARP inhibitor, but with a germline BRCA2 mutation like this in the blood, you should have detected that probably either in the history of the patient or in the solid biopsy. So,
Dr. Cheng, you are in UK, you have access to everything, let's say, and this is the report. Dr. Cheng, how would you approach this kind of
I would be very cautious because the New England Journal in 2012 already said the tumor heterogeneity, the longer you leave the tumor to mutate, it's a bit like COVID. There will be more mutation, more clones. And with a high TMB, you are going to generate more mutations. How do we know that this test, is a liquid biopsy is applicable? So I would think if something is odd, I would try and take a tumor biopsy. I'll be looking at AR receptors because ESR is raised. You're thinking, this is hormone no longer sensitive. If you think BRCA is mutated, you think, this is platinum sensitive. If you can't get access to olaparib, you might want to do a HRD just to confirm that. If you're really not sure this is a BRCA truly or not. So at this point, you're right. What Jeff is saying is having that blood is a limited sample, and there is a risk that we see only a small sample of the whole TMB. This is a very mutant. There's a lot of heterogeneity in the tumor. So I would be cautious about using this alone.
Fine. Dr. Chetan, Dr. Cheng says use caution, but we have been also advised by Dr. Chetan by someone else that, blood biopsies are going to be more useful. They can receive all the tumor shedding from different places. Heterogeneity is addressed by a liquid biopsy than a single site solid biopsy, and look at the tumor fraction, which is very high. So there are contrary advice to us. So what would you react? Liquid biopsies are authentic. That's what we think. And we should react to that. That's what we think. Dr. Chetan, what would you react to this advice?
Well, to be very honest, in my practice, I still stick to lesion biopsies whenever it is accessible. Only in cases of lesions which are inaccessible or they are going to jeopardize the patient's safety is the time when I resort to liquid biopsies, and that is also my policy in other malignancies, including lung cancer.
Totally agree. So you have to be cautious. And Dr. Bhushan, what should I do for this patient? These kind of complicated arrangements.
Yeah, as this is a complicated patient who's already received hormonal treatment in form of fulvestrant, so I would agree with people that I will give PARP inhibitor olaparib to this patient.
Fascinating. And
I will believe on a liquid biopsy.
You believe on the liquid biopsy.
Yeah,
that's great. Dr. Shivakumar, your advice, and then I will quickly go through the analysis and end up on this. Shivakumar?
Yes, sir. I don't see PIK3 mutation in this panel, sir. Is it really not detected or?
No, it's not detected.
Not detected. And then I have to go with what I have in my hand, sir. I think BRCA2 is WAP frequency of 72%. I have to go with PARP inhibitors than anything else.
Great. So I think this kind of a report is what Professor Jean Francois said. Call up and discuss. That's what all our previous people said. Discuss, and you can look at it in many which ways. The amplification of MDM2 is immediately therapeutic resistance to multiple agents, multiple chemotherapies. So that's one thing that you have already seen. and then you see an ESR1 mutation. This particular mutation, the D538G, has got the worst prognosis in the PFS and OS, and these are the common mutations that are described in the ESR. Remember, this is a HR positive patient, and our patient has got, this is the real patient, this is our patient has got a D538G mutation. So I can't discard this. This is clearly a patient who has become resistant on endocrine therapy, and the Bolero trial and the Sophia trial clearly tells us that this patient is already developed resistance to aromatase inhibitor, and is not a good choice to use that kind of drug, and probably not going to respond well with fulvestrant. And now we have emerging options, the newer SERDs which are addressing ESR1 mutation, and we have the phase 3 trial Emerald on Elextrant. That's the option for this particular patient. But then again, what confuses us is this BRCA2. Now there are data that clearly talks about BRCA2 mutation in hormone receptor positive disease. There is a prevalence of about 3.5%. And I have a pembrolizumab data that talks about high tumor mutational burden in hormone receptor positive disease. And last year we had the camrelizumab, which in a heavily pre-treated patient who has got a high tumor burden. So I have a plethora of options, and it's going to be very confusing. One may argue that this patient may be a candidate for a PARP inhibitor and an immune checkpoint inhibitor. And if you get an ESR1 mutant drug, maybe you can try that. So that's how one has to look at this. So the point that I'm trying to make is, it's complicated. Talk to everybody, talk to your patient. It's not easy. You may have the report. Still, it's going to be a tough ask. And with that, I think I will stop. And thank you so much for this opportunity. And thank all my panelists for their very patient answering to my question.
Yeah, thank you, Dr. T. Raja, for excellent discussion about this topic. Now I will hand over to Dr. Shyam Agarwal, sir.
Thank you, Dr. Nirni, for chairing this such an important and really very, very fascinating couple of cases which Dr. Raja brought in, and a great discussion highlighting that the field is really evolving at this point in time, and we must not be dogmatic on any of our advices based on the next generation sequencing. We must, I think it was reiterated again and again, that we must engage with each other, with the lab personnel, with the other medical oncologists, and look at the advice which is perhaps associated along with the report. So I think a discussion, and because some of these drugs are really expensive and the tests are expensive. So when you do that, the expectations of the patients become very, very high. And if you, after spending several lakhs of rupees, you get nothing out of it, and the same report is read by another physician and another team, etc., well, then, there's always a chance that, I would have done this, I would have done that. So I think, and I'm facing such situations in our current practice at this point in time, not only on the advice on what to do, but what labs to choose, because there is a plethora of labs now. So, and people who are rich, who are affording all this, they want the best. And the problem is the consensus between the reports of two labs is not there. So there are so many caveats at this point in time in precision medicine. And the bottom line, as I think Dr. Senthil pointed out, 5% or 4% clinical benefit out of all this, what you do. So, look at that, which means that 95% of the people are not going to benefit from these outcomes of the currently available labs and the reports. So I think we have to be extremely, extremely careful in, selection of labs, looking at the data, whether it is a liquid biopsy, whether it is a, solid tumor biopsy, so there are so many issues. So, don't become very casual or become dogmatic that, so I think Dr. Raja clearly said we need to discuss amongst each other and with the lab personnel so as to, be careful on advising on the basis of these reports. So I think with these few remarks, I'll hand it over to the organizers. Thanks everyone, all the speakers, all the moderators, chairpersons, and panelists for this really beautiful discussion on lung and breast cancer, and the insight into what's really available and what we should be doing. So with this, I hand it over to the organizers. Manish, kindly take over. Thank you very, very much for this opportunity. Thank you.
So thank you so much, Dr. Shyam Agarwal, for taking us through from being the program director. Thank you so much, Dr. Nitish Rohatgi, for moderating the lung cancer case discussion, and all the panelists for lung cancer. And thank you, Dr. Senthil Rajappa, for taking us to the Indian perspective of molecular profiling and precision medicine in treatment outcome. And finally, we had a wonderful case discussion from Dr. T. Raja, fantastically moderated, and really worthwhile to patiently listen and learn from him. So thank you so much all, and all the chairpersons, Dr. DC Doval, Dr. Mehboob Basade, Dr. Hari Chaturvedi, everyone for joining us on a busy Wednesday. And we vouch to take this forward, the academic platform of Concentric, in days to come with all your patronage. Thank you so much.
Thank you. Bye.
Thank you.
Thank you all.
Thank you, everyone.
Thank you.
Good evening. Bye-bye.
Bye.